Good afternoon and good morning to those of you on the West Coast. My name is Jessica Porras and I'm the Senior Manager for Education and Outreach at CAQH CORE. It's my pleasure to welcome you today to our webinar titled Save Time and Money Using EFT ERA Transactions. Before we begin, I'd like to mention some logistical items. You can download a copy of today's presentation from the CAQH.org website. To do so, please navigate to the CORE pull-down menu at the top of the CAQH.org welcome screen and select the CORE Education Events page. A link to the PDF version of the presentation can be found under the listing for today's webinar. On this slide, you can see a screenshot of the attendee GoToWebinar dashboard. You should see something that looks similar to this on the right side of your computer desktop. When joining today's session, it's possible you may have joined the audio portion of the webinar using your computer speakers by default. If possible, we'd prefer you to join the webinar audio by telephone. To do this, please select the telephone audio button in the audio panel of your dashboard, and the dial-in information will be displayed. Make sure you enter your audio PIN, which is found under your dial-in information. We will save time at the end of today's program to respond to your questions. But please feel free to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. We ask that when you submit your question, you identify the type of organization you're with so we can give you a more accurate response. We would like to thank today's guest speakers, Heather McComas, who is the Director of Administrative Simplification Initiatives at the American Medical Association, as well as Susan Kirsten, who is the Project Manager for the e-Payments Project at the Veterans Health Administration. Today we will start off with a presentation from CAQH CORE on the Phase 3 operating rules on EFT and ERA, including their key impacts, benefits for providers, as well as available resources. Then we're very happy to have the American Medical Association here, who will present on what they consider to be the benefits of automation, as well as provider advantages to EFT and ERA adoption. That will be followed by a case study presentation from the largest integrated healthcare system in the United States, the Veterans Health Administration. We're delighted to have the VHA here to share their Phase 3 implementation experience. Before we begin, CAQH CORE Senior Associate Drew Voitel will walk us through our first polling question. Drew?
Great. Thank you very much, Jessica. But before we jump into our first polling question of the webinar, I wanted to show this slide very quickly because we have asked this question since back in 2013. And so what we've been able to do is put together some good trend information here. And you can see back at a town hall on May 21st, 2013, most people were in the planning and analysis stages. And then beginning of this year, on January 7th, at our town hall webinar, we asked the same question, and the largest percentage, 47%, said that they had completed. So I just wanted to show this information and share it with the group before we jump into our first polling question of the webinar. And I will read the question, and then I will launch the poll where everyone can answer directly on their desktop. So this question asks, please indicate the extent to which your organization sends or receives healthcare payments through EFT. And this is the ACH network only. So I will launch the poll, and we will pause for a brief moment for everyone to be able to respond. And just go ahead and answer directly on your desktop. We'll take about 10 more seconds. Take about 2 more seconds. We're at 66% voted. Try to get that number up a little bit. And Bob, before we jump into your section, I might have you comment on these results. Great. 69%. See if we can get to 70%. There we go. All right, I'll close the poll and share the results. All right, as you can see here, those who responded, 46% said above 75% of the time. Then followed by 23%, 51 to 75% of the time, then 11%, 26 to 50%, 10%, indicating 1% to 25% of the time, and then a small portion saying that they don't either send or receive the EFT. So Bob, do you have any thoughts on this response, on these responses here?
Well, I think this is probably a positive response in that a majority of respondents say that a majority of their EFTs come through electronic payments rather than a paper check. And we have that kind of the opposite trend here. The majority of the payments do come through EFT. And we'll see that through the recent publication of the CAQH index, the study that we've just published at the end of March, kind of replicate some of these findings as well in this mini survey. So more to come as we move through the rest of the presentation on these numbers.
Great, great. Thank you, Bob. And hopefully that kind of just sets the table for the rest of the discussion today. So with that, we will move on to our first presentation by CAQH CORE Associate Director, Bob Bowman. Bob, take it away.
Great, thanks, Drew. And just as Drew and Jessica said, we do want to just provide you a quick level set on the core operating rules that are found in the third set, what they are, and kind of the impacts that they have on providers, and how we can ensure that providers receive all the benefits of complete implementation of the operating rules, along with the transactions themselves, the EFT and the ERA. The EFT and the ERA are the phase 3 rule set, and it's the second component of the operating rules that are required under the ACA mandate. And the compliance date, as Jessica mentioned, has now been over 2 years, and we're seeing a steady trend of increased adoption of the transactions, but still with a lot of room for growth. Even with our mini survey straw poll that we just did, you see that it's not 100%, it's not even 90%. So the sooner and the better we can get that adoption rate higher and more smooth, the transactions will ease the process that providers have in ensuring that they can auto-post the payments as well as auto-post the remittance advice information and clean up their AR. All things are very positive. So we'll hear more of this story as we go through today's presentation, especially with our guest speakers. On the next slide, you'll see that not only do the phase rules, the phase 3 rules are part of the federal requirements for the ACA, but even the Federal Register noted that there are specific barriers to their adoption. And the operating rules, along with the transactions themselves, are here to help providers move through those barriers. And one of the most significant barriers was noted in the Federal Register that the EFT and the ERA, they're separated in time from each other and by receipt of the provider. So it's harder for the provider to reassociate the payment with remittance advice data, therefore making it more difficult to process. They would then default back to their paper check and their paper remittance advice, so they can match them together on their own time and then process all manually. So hopefully with the adoption of the operating rules and as plans and vendor providers adopt them, they'll realize those benefits of an electronic transaction. On the next slide, you'll see that we are moving towards that type of adoption. Claim payments and the most recent index was top 61% adoption rate. So that was an increase year over year of over 4%, which was a little bit slower from the prior year of over 7%. But the trend over the 2 years is over 11% increase in the use of the EFT transaction, which is a great increase, but still obviously room for growth. We also see a similar rate of increase, over nearly 5 percentage points, for the ERA year over year from 2013 to 2014. Again, though, not even cracking 50% use of the ERA transaction. So many providers are relying on proprietary electronic transactions, a PDF. They're relying on a paper remittance advice, and they're doing and processing their AR in a very manual way. So this is costing both providers and plans and any intermediaries in between significant delays in processing their AR, as well as the cost of their resources in doing their books manually. So the best way, again, as you'll see throughout the presentation, in increasing the use of the transactions through the operating rules, the goal would be to reduce those significant costs that are a burden for both providers and health plans. On the next slide, you'll see that again, taken at a very basic level, that the EFT and the ERA operating rules really do represent that convergence of financial services and healthcare. Again, using the transaction from bank to bank in your EFT transaction, and the ERA from the health plan to the provider, potentially through intermediaries like your clearinghouse or a vendor or a billing service. These transactions arrive at the provider through two different ways. And so that convergence of these transactions through different industries, from banking to healthcare, is important for the provider to understand, as well as that the transactions have to come together to ensure that the provider can process them in a way that makes their end process simple and easy. So again, the ERA is just the electronic transaction that enables the provider to receive claim payment information from the health plans electronically, and the EFT is the payment. So those two, again, coming from separate entities to the provider, is going to be very important for the provider to process in a way that makes it easier for them to work their books and to work their AR. On the next slide, moving into the details, some of the specific requirements for the Phase 3 rules. The rules are divided up into two categories: data content as well as infrastructure. The data content requirements for Phase 3 include the uniform use of the CAQH and RARCs. These are the claim adjustment reason codes and the remittance advice reason codes. I'm sorry, the remittance advice remark codes, excuse me, for the 835. So there are a specific set of business scenarios. There's 4, so there's a minimum set of 4 business scenarios with a maximum set of codes of the CAQH and RARCs and group codes used within those 4. So the intent is to streamline the information that the provider receives in this specific business scenario, so they can understand these business scenarios very well and understand that all health plans are reporting this type of adjustment or denial in the same way. The infrastructure rules, there are 4 of those, and they're very specific to how the transaction is conducted. Starting with the 350 rule, this is the infrastructure rule that requires a master companion guide template, specific connectivity on how to conduct the transaction, the use of acknowledgments, as well as dual delivery. We do want to kind of wean providers off the paper process, the manual process that they have, and to do that, to move them to a fully automated electronic process takes time. So that dual delivery, or receiving both paper remittance advice, proprietary electronic remittance advice, or an electronic 835, that process may take some time for providers to adapt to. So the rule allows for that time frame. There's also the Rule 370, the EFT ERA reassociation rule. This requires the provider, allows for the provider to request information to allow for that reassociation. Again, since they come from 2 different entities to the provider has to reassociate the payment with the ERA. It also allows for the elapsed time from receipt of those 2 transactions, with a requirement of a 6-day window between the EFT and the receipt of the ERA. It also has, if there are missing EFT or ERA transactions, how can a provider address those missing transactions with the health plan? Those are specific requirements that health plans have to publish. There is also the recognition of the role that NACHA operating rules play for the financial institutions in regard to the EFT transaction, or the CCD plus transaction. That's a component of the HIPAA standard for the payment. And last but not least, there are 2 rules related to the enrollment of the EFT and the ERA. This allows for providers to enroll electronically to receive these transactions with a health plan. It's a complete data set, so the same data is requested of providers from all health plans. So it makes it very easy for the provider to enroll with a health plan to receive these transactions. On the next slide, you'll see that there are very specific benefits generally for this operating rule set. So for the entire EFT ERA operating rule set in Phase 3, it's hoped that the standardized electronic enrollment for EFT and ERA will allow providers to enroll for these transactions in a very easy way. It's a very consistent set of data and hopefully a more streamlined process. There's also the potential reduction in manual claim rework. Again, with a very specific set of business scenarios addressing the 80-20% problem that providers have with denials and adjustments and working those, it's hoped that the data content requirements will help providers manage those types of requests they have when they post those payments and post the remittance advice data. Also, with the information coming in more timely. There is reassociation data to allow the provider to reassociate the EFT and ERA more easily. It will help reduce the AR days that the provider faces. The savings that have been estimated by the industry through the Federal Register is anywhere from hundreds of millions to even billions of dollars over just 10 years if providers were to adopt the transactions, both the EFT and the ERA, for all of their payments and all of their bills. So that's significant savings that providers can have in a very short amount of time. Again, the time frame, we've already passed the compliance date, and we'll see that more and more of the industry is adopting the operating rules and implementing those to ensure that they receive those benefits. Again, the hospitals and health systems are working with their trading partners to achieve the benefits. On the next slide, making sure that we address specific provider actions. The provider first has to determine if they are using or conducting the transactions. Are you receiving an 835 and the EFT transaction for all of your bills, from all of your health plans? If not, there's a way to address those types of questions and ensure that you have the information that you need from your payers to enroll for both the EFT and the 835. Number two is to go ahead and actually, make sure that the graphics come out there for you. Understand the health plan agreements and options for payment and remittance advice information. Again, every health plan will have their enrollment process for you. It's all electronic, hopefully, at this point, along with a data set that you must complete and complete that process. We do provide a sample letter for the EFT request for providers to use it for free on our website. You see a link here on our slide. That will allow you to request that information from the health plan. Number three is to contact your bank to request delivery of the reassociation trace numbers to ensure that you can reassociate the EFT with the ERA. We also have a sample provider letter that can be used to have that conversation with your bank as well. And lastly, providers can address questions with their vendors. You may have a PMS system, you may have a clearinghouse that you use. You want to make sure that their systems are aligned with your systems to ensure that you can receive the benefits of all of the data coming on the 835, as well as payment information in the EFT, to make sure that it posts to your billing and collections as well as your own treasury process. So your vendors also have a component to play. So you need to communicate with both your bank, your health plan, and your vendors to ensure that you as a provider are receiving all of the benefits of the Phase 3 rule set. If we move on to the next slide, we do want to address some of the problems that the rules do attempt to address. The first is the lack of uniformity in the code combinations. Previously, there were nearly 1,000 VARC codes, 300 CARC codes, and 4 group codes. And every health plan kind of developed their own way of reporting how a particular claim or claim line was adjusted or denied. And every health plan did it their own way. They mapped those codes their own unique way. Again, some of them may have been consistent across the board, but many thousands of them were not exactly mapped the same way. So it was the burden on the provider to figure out, well, Aetna does it this way, and Humana reported it this way, and United and Blue Cross did it this way, and every health plan, the 12 health plans that I bill on a daily basis, all did it just a little bit different, just a shade or a hair different. The burden was on the provider to make sure that when they posted the payments, they could figure that out. With the operating rules for consistent use of CARCs and VARCs, with the 4 main business scenarios, again, addressing the 80-20 problem, looking at that huge chunk of 80%, if we can get all the health plans to, for these 4 scenarios, missing data or missing an attachment that's required on the bill, on the claim, to report it in a uniform way, using this CARC, using this VARC, with this group code, it's hoped that the provider reap the benefits of making it much easier to post for those 12 different plans that you bill. You can easily post that information, hopefully even becoming more automated over time, using the 835 and using the EFT to your AR, making it much easier for secondary billing, for example, billing out to any member bills that might be due. So that's what the CARCs and VARCs rule addresses. If we go on to the next slide, the uniform use of the CARC codes, or these adjustments, because there was such a wide diversity of use, funneling into that streamlined code set makes it much easier for the provider to no longer need a manual follow-up with the health plan. Hopefully you're not on the phone trying to understand why a claim line was adjusted. for a particular reason. It should be much easier to read. Again, you can reduce any errors with secondary billing, inappropriate write-offs or billable charges, incorrect billing of patients for copays and deductibles, and posting delays for that information. All of that can be reduced with a streamlined code set. Then on the next slide, moving into another component of the operating rules that it addresses is the enrollment for the ACH and the EFT and the ERA. Again, we want to simplify that process for providers in enrolling with a health plan. Every health plan does it just a little bit different, again, making it burdensome for the provider. So the operating rules address the situation where providers need to enroll, as well as if the provider, it accounts for if the provider does their billing themselves or if they've outsourced that to a billing service. It incorporates all the lessons learned from the increased enrollments and meeting the industry-changing needs as things change in the process for billing and remittance advice processing. It enables health plans to collect standardized data for complex organizational structures. We all know that not every provider office is exactly the same, from jumbo provider groups to small groups to micro offices to pharmacies. Everyone does it just a little bit differently, how they have that arranged. And the data rule set for enrollment accommodates all of those, all that variability in the provider community. If we move on to the next slide, there are resources for the EFT and the ERA as well that are available. Again, there are sample letters that are provided on the CAQH CORE website, as well as a link here, again, so that providers can ensure that they request the right information from the health plan or from their bank for the EFT. You can use the sample letter really as a template to talk to your bank or to talk to any of your health plans. The tool also includes background on the benefits of the EFT, the key steps for providers to use, and the actual letter template that you can easily cut and paste from to make sure that you understand exactly the communication that you need to have with your bank. Moving on to the next slide. There is a solution, an industry-wide solution that CAQH does have in the marketplace, and it is Enroll Hub. It is free for use by providers. It is web-based, so providers can just go out to our website and use this tool to key in specific demographic information about yourself as a provider. Again, the data set is aligned with the operating rules. It is completely web-based. It allows you to identify which health plans you wish to enroll for EFT or ERA. So if you haven't enrolled with a number of health plans for EFT and ERA, this is kind of a one-stop shop. The provider keys in the information. They push that information out to each of the health plans that they wish to enroll with. The health plans receive that information and can process your enrollment all automatically behind the scenes and hopefully not bug you at all. So that there is obviously lots of information available on our website around the Enroll Hub, and there are many, many health plans that have now adopted this as a solution for them to enroll. So you don't have to go to each individual health plan and find it on their website and do it 12 different times for those 12 different health plans that you bill for. You do it one stop, one process using the CAQH Enroll Hub. With that, I believe we'll move on to our next polling question. So I'll hand the call back over to Drew. Drew?
Wonderful. Thank you. Thank you very much, Bob. That was a lot of great information. And this brings us to our second polling question of the webinar. And just like last time, I will read it and then launch the poll for everyone to respond. And this question asks, please indicate the extent to which your organization sends or receives remittance advice using the ASC X12 version 5010-835. And I will launch the poll, and we'll pause for just about 15 seconds for everyone to respond. Take about 10 more seconds. About 3 more seconds. About 63% have voted. Try and get that up a little bit. All right, I will close the poll and share the results. And so the largest percentage, 40%, say above 75%, followed by 27% who indicate it's not applicable. 19% say between 51 and 75. 9% say between 26 and 50%, and then the smallest percentage at 5%, indicating just 1% to 25% of the time. So with that, we will move on with our presentation. And I would like to introduce Heather McComas, who is the Director of Administrative Simplification Initiatives at the American Medical Association. Heather will present the AMA's perspective on the benefits to providers of EFT and ERA adoption. Heather, go ahead, please.
Thanks, Drew, and thanks so much to CAQH CORE for inviting us to participate in this webinar today. We're very passionate about this topic, and we're pleased to be involved with this event. Go ahead to the next slide, please. So I'm sure that most of you are familiar with the American Medical Association, but we are a national physician association with a mission to promote the art and science of medicine and the betterment of public health. We currently have 3 strategic focus areas. The first is improving health outcomes and involves our initiatives to prevent diabetes and heart disease. Second is creating the medical school of the future. And the third is creating thriving physician practices. And our topic today fits neatly into that last focus area of thriving physician practices, because standard electronic transactions like ERA and EFT can greatly improve practice efficiency and ensure the financial viability of physician practices. Next slide. So the AMA is very involved in administrative simplification activities in the industry. We support the development, maintenance, and implementation of technology standards and operating rules to reduce administrative hassles for physicians and their staff. We support practice automation to improve efficiency, and most importantly, to maximize the amount of time that physicians and their staff can spend with patients. That's really why they do their jobs, and we want them to have as much time as possible to spend in patient care. We work a lot on developing electronic standards and the associated operating rules, and to that end, we actively participate in the CAQH CORE operating rule development process. Next slide. So standard electronic transactions like the ones we're talking about today, the ERA and the EFT, offer providers a uniform way to conduct business across all health plans. And this is really important because from the provider perspective, it's really a challenge dealing with all the variation in how health plans process claims and pay providers. So the uniformity offered by standard electronic transactions is very helpful. And then on top of that, the operating rules further increase the standardization and uniformity of transaction implementation. So this is obviously an additional benefit for providers. Implementing ERA and EFT, particularly when it's done together, can boost practice efficiency and save time and money. And Bob was talking about the 2015 CAQH Index, and that report has some interesting information in terms of potential savings from transaction implementation. And so the index shows that for each payment, providers could save 56 cents if they switch from paper check to standard electronic funds transfer. And then for ERA, if they switch from a paper EOB to the standard ERA, they could save $1.11 for each transaction. So if you extrapolate that out for all providers and all transactions in a year, the industry could save, from a provider side at least, $160 million for EFT and $302 million a year for converting for ERA. So there's a lot of obvious savings on the table for providers by using these standard transactions. Go ahead to the next slide. So there's some specific advantages for adopting ERA for physicians. As Bob was talking about, those standard messages related to denials and payment adjustments can really help providers, both in terms of enabling automation, but also especially easing the communication regarding the reasons on the remittance advice. That one nice slide that Bob had kind of showed, like, I thought it was like Rubik's Cube and showing all the variation in health plans. And these standardized codes and code combinations can really help practices understand the remittance advice messages that they're seeing. The electronic remittance advice also enables a lot of automation in the practice, and it frees up, by enabling auto posting, it frees up the practice
staff to do more high-value activities, things like digging into a denial and finding out what was wrong, and perhaps resubmitting the claim or submitting an appeal if it's appropriate. So it allows the practice staff to do higher value activities rather than just manual posting of payments. ERA usually allows for faster payment from payers, which is obviously an advantage in improving practice cash flow. And again, we'll say this many times, I'm sure, during the course of this webinar, but implementing ERA and EFT together enables for automation and a lot of time and cost savings. Go ahead, next slide. So with any workflow change, there is a potential for some challenges, and there are, of course, some related to ERA implementation. Bob mentioned the challenge related to health plans all having their own ERA enrollment process, and that is a challenge, obviously. That's why the Enroll Hub tool that Bob pointed to is a really great option for providers, and can now it basically offers a one-stop shopping for enrolling an ERA across health plans. And we would highly encourage all health plans to be a part of the Enroll Hub tool because it does encourage provider adoption of this transaction. It's also sometimes confusing for practices because each health plan has a kind of different timeline and process for their ERA rollout with a practice. So that's why communication with the health plan during the implementation process is so important. And as Bob mentioned, and as part of the operating rule, plans do offer paper remittance for a period of time after the ERA switch is flipped on, so the practices can become comfortable with the ERA and confident that it's accurate before they stop getting the old paper EOBs. One unfortunate thing is that sometimes health plans ERAs may not balance, and this is actually a compliance issue. The 835 ERA standard requires the transaction to balance, so if a practice experiences this with the health plan, they should definitely push back and bring this to the health plan's attention and point out it's a compliance issue. And then there is variance in the level of vendor automation of the ERA transaction. Some offer more automation than others, so it's important to talk to vendors and determine their level of automation of the transaction, because obviously the more that the computer can do for the practice, the better, and that frees up staff to do more, again, higher value activities. Next slide, please. So there are also benefits associated with EFT adoption. Again, it minimizes staff time on manual processes and allows for a lot of automated payment posting and reconciliation. Again, it opens the door to faster payment from health plans and improved cash flow for the practice. It also reduces some of the potential risk associated with paper checks. We all know that paper checks can be lost, it can be stolen, there's potential for fraud. So EFT eliminates those risks associated with paper checks. And then also EFT reduces the costs and hassles associated with paper checks. You know, you don't need to endorse the checks anymore. You don't need to send someone to the bank. So again, you're saving time and money by switching to this electronic process. Next slide, please. There are some barriers to EFT adoption. Again, we have that multiple payer enrollment procedures hurdle, and again, I would point to Enroll Hub as a great way to circumvent that problem. And then Bob also mentioned the kind of challenge involved sometimes in reconciling the ERA with the EFT and reconciling the remittance device with the payment. And that's why that reassociation trace number is so important. It's important that providers know to ask their banks for that reassociation number so they can take that number from the bank, from the payment, and then find it in the ERA and then link up the payment with the remittance device. We'll be talking about this a little bit more in just a minute, but there are some non-standard forms of electronic payment, such as virtual credit cards, that we believe are detractions and distractions from adoption of the standard form of EFT. And then also we were hearing about some payment solution vendors assessing percentage-based fees for the standard EFT transaction, and it's important for providers to understand that they are right to standard EFT with no percentage-based fees. We'll talk about that a little bit more again in a minute. And then there's just some general confusion and misinformation out there about EFT that is a barrier and needs to be cleared up to get out of the way of providers adopting this practice automation. Next slide. So in case you're not familiar with virtual credit cards, they are single-use credit card numbers that health plans send to practices to pay for claims payment purposes, and the physician's office manually enters the credit card information into their credit card terminal as it would a patient credit card. Go ahead to the next slide, please. And so there are some potential disadvantages associated with virtual credit card payments. The major one, and the one is very concerning, I think, to providers, is the fact that they can have a major financial negative impact on the practice. There are fees associated with virtual credit cards. There's a transaction fee, but more concerning, there's a percentage-based interchange fee. And depending on the size of the claims payment, that can be a big chunk of change and can really add up to the practice and affect the bottom line. And also it's important to note that there is a shift in payment processing costs for virtual credit cards from the health plan to the provider. While the providers are, again, getting hit with these fees, the health plan might actually be getting a rebate for the credit card company, so they're making out pretty well, and this is, of course, kind of an imbalance and concern from our perspective at the AMA. The virtual credit cards do involve manual processing, typing in those credit card numbers into the terminal, and of course we all make mistakes. If there's an error in that punching those numbers in, then the card is rendered void and the health plan needs to reissue it, which delays payment. And then finally, it's important to note that the virtual credit card information cannot be carried in a compliant fashion in the current version of the ERA 835 transaction. So that obviously causes a lot of reassociation challenges. Next slide, please. So this slide gives us an example of the potential financial impact of virtual credit cards, particularly if we compare it to the standard EFT. So for a $5,000 claim payment and a 3% interchange fee, the practice would be charged a fee of over $150. So it might not sound a lot, but if you add it up across, during the course of a year across health plans, it can be thousands and thousands of dollars for a practice and a substantial loss of income. And even though a practice might choose to accept virtual credit cards in some instances, if it's a health plan they don't do much business with, and enrolling an EFT for a single payment might not make sense. We believe that in many cases that virtual credit cards can really affect a practice's bottom line in a negative fashion, and it's important that practices be aware of the fees associated with these cards and certainly have a choice in the method by which they receive health plan payments. Next slide, please. And so just a couple misconceptions about EFT. Sometimes we hear practices are worried that, oh, EFT is going to require a lot of fancy technology. It basically just requires a bank account, and I think that all practices already have a bank account. Using ERA at the same time, which we would certainly recommend, might require some technology changes, but we would argue those are well worth it for the efficiency gains. We hear about providers being concerned about giving their banking information to health plans, and concerned that the health plan is going to reach into their bank account and take money back for overpayment recovery, but the ERA standard does not permit this kind of ACH debit. So we'll talk about that a little bit more in just a second. Next slide, please. And then we are hearing again about these percentage-based fees associated with the standard EFT, and some vendors might have some additional services that they charge these fees for, but and a practice might want to pay for those services, and that's fine, but it's important that providers be offered at least the same basic standard EFT at no charge with a percentage-based fee. Practices should certainly ask for that if they're not given a no fee option, and essentially the basic form of ACH EFT is like direct deposit and should be available at no percentage-based fee cost. Next slide. And again, it's important that providers know that EFT enrollment does not grant health plans authority to process unauthorized debits, and if practices are concerned about this, they should contact their bank and they can ask about some additional protections on their account to ensure the health plans cannot take money out of their account. Next slide. So if you do encounter any health plan issues or compliance issues with the transactions, you should first contact the health plan and try to resolve it with the compliance officer. If that doesn't work, there is an official complaint process through the government. The National Standards Group has a website, and there's a tool called the Administrative Simplification Enforcement Tool that the link is shown there that you can go to report any complaints with the transaction and get them resolved. Next slide, please. And jump ahead to the next slide. There are obviously a lot of benefits to EFT and ERA, and sometimes new things are scary and intimidating, but the good news is there are a lot of free resources out there to help you implement these transactions. And I, of course, will first Plus AMA resources, we have electronic transaction toolkits available at our website at Go ERA and Go EFT. Lots of great information there. And then I'll also point you to the Healthcare Administrative Technology Association ERA EFT Resource Library. You can go to the next slide. And this is a nice resource because it pulls together a variety of available industry ERA and EFT resources from AMA, from CORE, from CMS, from NACHA has a lot of great provider resources available. So they're all kind of one centralized place you can get all that information. So that's it, and my information email is here if anyone's interested. Oh, I guess it got taken out, but certainly we can answer questions afterwards if you like. Thanks so much, Drew. I'll pass it back to you.
Thank you. Thank you so much. That was a lot of great information. And now we are jumping into our third polling question. And just like last time, I'll read the question and launch the poll for everyone to respond. And this one asks, which of the following was the biggest challenge to your organization's implementation of the CAQH CORE EFT and ERA operating rules? So I will launch that poll, and we'll take just a few seconds to respond. And I guess while you're answering, the reason we ask this question is because we want to know how best we can help you, whether that's developing new education sessions, new resources for our website, perhaps who from the implementer case studies to bring onto our webinars. So this is to help Jessica and I. We'll take about 5 more seconds. We have about 50% who have voted. We might pause just a few more seconds to get that number up. All right, we got 60% voted. We'll take that. I'll close the poll and share the results. Well, I'm seeing 41% indicate that they did not encounter any challenges or it's not applicable. Then 23% said it was fully understanding the operating rules, followed by 18% both overcoming the resource constraints and then identifying and completing necessary system updates. And then 50% said working and testing with your training partners. And if you have other challenges as you're going through this, always feel free to reach out and contact us. We're happy to help you. So I will get that off the screen, and now we will move on to Susan Kirsten, who is the project manager for the e-payments project at the Veterans Health Administration. And Susan will present the VHA's Phase 3 implementation experience. Susan, go ahead.
Thank you, Drew. I will say that this is more or less a case study, and we have found many of the things that Heather just went over. So you'll kind of hear a 1-2 punch on this today. So first of all, everybody hears about the Veterans Administration, sometimes in ways that we don't prefer, but just to give you an overview of who we are and what we are. We have 1,277 locations across the nation that consist of both hospitals and community-based clinics. We see over 6 million patients annually across the nation. We have approximately 277,000 employees, with 74,000 of them being our doctors and nurses. And we are part of the congressional budget. However, within that budget, they estimate what they expect for us to collect in revenue each year. And for fiscal year 16, we are expected to collect $3.2 billion by billing insurance companies and veterans co-payments. And this actually goes back to each VA for care for our veterans. So we are very passionate about our collections. Next slide. In 2003, when we first implemented the ERA and EFT transactions, our volume was very low. But as the rest of the industry began implementing the ERA transactions, obviously our volumes grew. However, EFTs took a lot longer for people to adopt and implement, so that part of it was very slow until the operating rules were published in 2014. Next slide. Although the EFTs weren't initially mandated, our process included for each and every payer that we would ask them what is their EFT status, and that we also let them know we would only accept CCD plus EFTs. The CCD plus format was actually the challenge for the payers more than just an overall EFT capability. But as was already mentioned, the CCD Plus is the format that allows us to reassociate the EFT and ERAs, and so that is what we required, and that is what we built our software around, is the ERA and EFT format, and of course being able to connect those two together in our system. We were very pleased when the operating rules came out and said that CCD Plus was the official format. We didn't have to do any software changes based on that, so we are pleased with that. Next slide. So once the operating rules became public, the VA took a very proactive outreach approach. We sent letters to all of the payers that the VA was currently billing, requesting EFTs by the mandated date. The letters included a survey we requested the payers to return with questions such as, do you have EFT capability? What is your EFT format? What is your date of implementation? As you can imagine, we received back varied responses, with a subset of them not ready or even aware of the change in the law. As it turned out, phase 2 of our outreach was educating these payers about the law and also about our testing and implementation process. For the most part, our outreach was well received. We did have a few payers that responded they had no intentions of ever sending us EFTs. The outreach team then worked diligently to find the right person at the payers organization to discuss EFTs, the law, and their compliance to it. They had great success with this phase of the outreach. In rare occasions, we had to reach out to the CEO, alerting them of our findings and the next step, which would be a formal CMS complaint. I don't recall us actually having to submit any formal CMS complaints in this process. The approach was very time-consuming. However, the VA is seeing the fruits of our labors, and it was time well spent. Next slide. VA currently works with 2 healthcare clearinghouses for our ERA and EFT transactions. They assist us with contacting the payers, educating them on the proper ERA or EFT format, and also our transaction testing requirements. Our clearinghouses also find out the payer's unique enrollment requirements, so the VA will know how to enroll once the testing is completed. Quite often, our clearinghouses work with the payer clearinghouses. There are many benefits to using clearinghouses. However, it does add a challenge of additional failure points to research when we have transaction anomalies or failures that we have to work through. But as I mentioned earlier, we believe the proactive payer outreach was well worth it. As you can see, currently we are receiving ERAs from 290 of our payers, with 1,932 payer TINs and 207 EFT payers with 1,553 payer TINs. So what do all these payer numbers and TINs equate to? Next slide. In March, our EEOB volume hit an all-time high of 1.1 million EEOBs across the nation. Overall, our revenue for the month of March was $231 million, and of that $231 million, we received $202 million in EFTs, which is 87.6%. We have found this very exciting. We enjoy watching our numbers go up. Definitely the fruits of our labor with our initial outreach, and also continued follow-up with payers, ensuring all enrollments are completed for all facilities and all plans, is we are reaping the rewards of that by these numbers. Next slide. So Heather touched on quite a few benefits of the ERA and EFT, and I'll just touch on the ones that we see from the VA. Some of the highlights that we've seen are standardized information for all payers, uniformity of the same CARCs and RARCs, the ability to enhance our software to process no-touch receivables, or as we like to call it, touch by exception. We only have to actually touch or work with those that cannot be auto-posted. The ability to track and trend the standardized CARC RARCs being used, and also with that no-touch claim adjustments based on the CARCs and RARCs sent by the payers. We can't minimize the impact for us of quicker payments. We have seen some cases where our accounts receivable are closed within 10 days of billing due to these electronic transactions. In addition to closing our accounts receivable quicker, this also allows us to credit our veteran co-payments timely, reducing their financial burden. Next slide. Now I'll just touch on a few ongoing challenges, which are basically the same challenges that Heather just brought up. All good programs do have challenges, and this is no exception. The first one I want to mention is what we have found to be a convoluted enrollment practice. We have found that over the past, some payers have actually disenrolled providers when we've asked them to enroll additional providers. So when you look at the number of facilities that we have, sometimes we have to do phased enrollments based on payers' enrollment needs. And with this, we've seen, okay, great, we turned on this facility, but then we find out a couple months later, oh, when they did that, they disenrolled others. And that's something that is within some of the payer systems, and we have seen that with more than one payer. We found that I apologize. Another challenge we've encountered are payers that use proprietary PINs or codes rather than NPIs. This has been a real challenge trying to track down what those PINs are or what those codes are. Nothing that is known to the provider, and on each of these we've actually ended up having to get on a phone call and have sometimes some pretty lengthy phone calls or several phone calls with payers to get to the root cause of what are these PINs or what are these codes. As for the PINs, we actually recently reached out to CMS for a formal ruling regarding the proprietary PINs. We have one payer that we literally had to enroll hundreds of PINs that were unknown to us, and they were being updated and changed, and this created quite a backlog for us in order to know exactly what to enroll and how to enroll, and this kind of thing. So we have reached out and asked if we could please get a formal ruling whether or not that is HIPAA compliant. Next slide. Then also what was already touched on is the biggest challenge that we currently face, as with others in the industry, with the EFTs are in the realm of credit card and EFT fees. We have been told by payers or the clearinghouses that they believe sending credit cards meets the EFT mandate, but as was said earlier, that does not meet the mandate. What we have done with the VA is if we have found a payer that has began sending us credit cards rather than EFTs, we just call them and say, we won't accept these, please stop these. And it may take a payment cycle or two, but we haven't had anybody push back and say, no, you are forced to use the credit card. They don't force us to use the credit card, but what I will say is that they have sent them to us without us requesting them. If we request an EFT, suddenly we get credit cards without us actually enrolling for them. So in some cases, it's felt a little bit like a bait and switch, but I will say that in those instances, the payer has turned them off when we've asked them to. So we haven't had a lot of pushback on that, which is good. The other thing, of course, are the EFT fees. We've been told that it could be anywhere from 2 to 5% per EFT. I know that Heather gave an example of one $5,000 credit card and with the fee. And if you look at EFT fees, if you do 2 to 5% of those with the numbers that we're bringing in, that is pretty significant. And of course, we take a stance that we will not pay those fees. Each one of those fees that we would have to pay, if we paid them, that would take money out of the VA hospitals, and that would mean that it would impact the care to our veterans, and we're unwilling to do that for an electronic transaction. And not only that, it's an electronic transaction that has been mandated by law that we're trying to follow. So we made a very hard line in the sand that we do not pay any fees. Next slide. And then just to kind of wrap up what the outstanding issues are that we have encountered with implementation is that we have had that some payers require an electronic claim or an 837 in order to send us an ERA or an EFT. And we've pushed back and asked, where does it say in the law that we must send an 837 in order for them to send us an 835? And nobody can show us that in the law, and we haven't found it in the law, but it still is the stance that many of the payers take, and we continue to go down that path of fighting the good fight to say, no, this is not what the law states. The next thing is that we find that we have some payers that believe that they have met the intent of the law if they send us some ERAs and EFTs, as long as they have sent it for some plans that they have now met and exceeded what the law states, rather than sending it for all plans. again, this is another thing we go back to the payers that said, no, there's nothing in the law that states that if you, as long as you send some, that you're meeting the intent. So we go back with those payers also. And as has been said before, that I think we need official regulations that to come out that say that should prohibit the payer fees for credit cards and EFT payments. And then if we could just simplify and streamline the standard enrollment processes. I know CAQH has their own enrollment system, but a lot of payers that we work with are not on that, or not one of the CAQH payers. And then it becomes, some of them are electronic, some of them have their own form, proprietary forms, some of them require a wet signature, some of them require an electronic signature, some of them want the signature from our clearinghouse, some of them want the signature from us. I mean, it goes on and on and on, and you almost need a PhD if you really wanted to know what was going on with some of these payers with enrollment. So if that could be simplified and streamlined, just as the transactions are, that would be fantastic. Next slide. And then I just wanted to say thank you for the opportunity to share with you what our experience has been on this. We have, as I said earlier, we have enjoyed the benefits of going through all of these processes with the ERAs and the EFTs, and we have achieved much success. And we look forward to the rest of it. Hopefully, if we speak again, we'll be able to show you that we're over 90% or maybe over 95%. That's our goal, is to get that high. So anyway, thank you very much. Drew?
Great. Thank you so much, Susan. And this now brings us to our fourth and final polling question of the webinar, and this has to do with EFT and ERA implementation benefits. And this question asks, has your entity experienced any of the following benefits since the January 1st, 2014 EFT and ERA operating rule and healthcare EFT standard implementation date? And this is check all that apply, so there could be multiple. So I will launch that poll right now, and we will pause just very briefly for everyone to answer. And immediately following this, we'll jump into Q&A and get to as many questions as we can. So after you vote, be thinking about questions you might like to submit. We'll take about 5 more seconds. We have about 45% who have submitted a vote. See if we can get to 50, and then I'll share the results. Take about 3 more seconds. 48%, 49%. All right, there we go, 50%. We'll take that, and I'll share the results. And so the largest percent, 64%, indicate an increased payments via EFT, followed by 43% down at number 4, improved EFT ERA enrollment processes. Then 33% indicate improved reassociation of EFT and ERA, and 27% indicate a more standardized use of CARCs and RARCs. And then 17% indicate no measurable benefits. So thank you for answering that whole question. Now I will pass it off to my colleague, Jessica.
Thank you, Drew. So we don't have too much time, but I want to get through a few audience questions. So let's just get straight to the questions. This first question is for Heather, and I know you talked about this during your presentation, Heather, but I think if we're getting questions, it's probably good for you to emphasize. The question is, how do you explain to healthcare providers to reject forms of payment such as credit cards?
Sure, thanks, Jessica. So, you know, I think first of all, it's important for providers to be aware of the potential downfalls of accepting the virtual credit cards, and you know, the fee issue, obviously, and you know, and so when if they get a virtual card, that they immediately contact the health plan or the in between vendor and say they want another form of payment, and to be persistent about that. You know, Susan indicated, and we've heard, and I don't mean to be discouraging about this. I mean, sometimes it can be a challenge, as Susan indicated, and it can take a little time, but then really push back and say we don't want to accept these and don't process them when they get received into your billing department. But we also think it's really critical, of course, that we advocate strongly, and this is kind of a policy issue, but the AMA advocates that this is really an issue of provider choice, and that providers should not immediately be sent virtual credit cards, that they should be contacted by the health plan and offer the choice and inform that there's fees associated with it, so that it's a proactive decision versus something that's sort of just forced upon them. And then the final point I'll make is that, and Susan indicated, the EFT payment is the standard and it's mandated, and so if a provider requests that form of payment, the health plan must provide it. And she indicated some health plans right now is not acting like they hadn't heard of it, but the health plan says that to you, there's no way out of it. They are forced to offer it to you upon provider request, and so that's the surest way to ensure that you're stopping the virtual credit card payments, because if you request EFT, the health plan absolutely must give you that form of payment. So I think that's one of the provider's best defenses against the virtual credit cards, is to request a standard EFT.
Thank you, Heather. And then our final question is for Susan, and the question is, please include information regarding how a failed EFT payment can be handled.
Well, when you say failed, I'm assuming that means failed from the payer. So really, this is where using a clearinghouse has really benefited us. We have our healthcare clearinghouse does see if they come in and they are a non-CCD plus transaction, or for those of you who may not be aware of what the CCD plus is, you don't take care of that piece of it in your world. The CCD plus includes an addenda record, and that's really, the addenda record is where we have seen the failures for the EFT transaction. And our clearinghouse watches to make sure that it is a correct EFT transaction. And if it is not, they go back and tell the payer, hey, this is wrong, this is incorrect, this is the format we need it in. And then again, sometimes it might be that the payers change something in their system, and whoever made the change may need a little bit of education. And then our clearinghouse will send them documentation that just gives all of the information about the EFTs and work with them to send it to us again. In some cases, the payers, if their bank or the clearinghouse that those EFTs came from, are unable to turn that around, turn that EFT around. They tell us we can't retransmit it for whatever reason. Then we request and require and follow up regularly on the fact that then they must send us a paper check. So that, of course, we have to get that payment. But then, if necessary, work with the payer and say, was this a one-off thing? Is there a change in your software that we now need to make a change with? And then our clearinghouse, and sometimes they'll get us involved and then just saying, what's the date of resolution on this? So this is really a huge benefit to working with a clearinghouse rather than trying to have individual connections with each payer.
Thank you so much, Susan. And so with this, we are out of time. I want to thank our speakers and also thank our audience. This next slide includes some of our future webinar programming. Also, if you want to make sure that you're in conformance with the operating rules, consider core certification. There's some information about that in the next slide. Also, if you just have any questions or want to engage with us on anything, the next slide, slide 56, includes a bunch of hyperlinks that will hopefully help you engage with us. And that's it. Have a great afternoon, and we'll see you during our next webinar.